Good morning.
Good morning.
Loretta, I love your little heart next to the L. We're getting close to Valentine's Day. Good. And Sue McCrary, you're the first to put in your name and your center in our chat box. So thank you for getting us started today. So everyone take a moment, each individual who's participating at your center, names and center names, and Karen Bleck will be on the call to make sure that we capture everyone for registration. And we'll get started in just a minute. It takes a minute or so for everybody to have an opportunity to log on and to complete the chat box. And one last reminder for everyone to put in the chat box your facility name and each individual. We would appreciate both first and last names just because we have to reconcile it with our registration. So it would be helpful if we could have both first and last names, please. Okay. Well, good morning and glad to have everybody here for session 9 of our Project Echo. And I'm going to begin by sharing my screen. A moment to get to PowerPoint for today. Alrighty, so here we are. Today's session is focusing on the multidisciplinary team and our work together in our different silos of care and expertise to both prevent and treat COVID-19 infections. And I'll add, your Genesis leadership really wanted us to think about how all care, quality of care measures are influenced by our efforts as a team to work together, and particularly during this time of staffing challenges, infections, understanding new information in new ways and new regulatory requirements. So how we work together to effectively communicate change and how we continue our work. So today, again, with our welcome to everyone, being sure that everyone is in the chat box for your first and last names and your facility names so that we have the accurate registration. Want to spend a moment debriefing from session 8, where we talked about caring for our staff with COVID, to see if there were any additional comments or thoughts or new concerns after we finished that session. And as we're doing that, I'm going to ask now that everybody put in the chat box 5 words or less, because we're using that quality improvement strategy of high-level boxes of areas to improve quality. So in the chat box, I'd like 5 words or less and how your interdisciplinary teams can improve COVID care. What are your strategies for teamwork in COVID care? Then I'll show you a brief review of the literature that I found in discussing teams and communications during this time of COVID pandemic. And then we'll do a little more discussion of this topic. We'll then get Dr. Bogoslavsky's perspective as our IHI quality improvement expert, and then we'll do a wrap up in preparation for next week's session as well. So with that, well, I'm going to ask I'll stop sharing my screen, ask individuals to let me know if there's any thoughts from last week's session, and begin to put in the chat box 5 words or less in how your interdisciplinary team is effective, or strategies you're using to enhance communications and teamwork in COVID care. And I see we've got a few more folks here that have joined us and put names in the chat box, so very good. So as you're thinking about the chat box and a few words, great start there, Brian. Anyone want to unmute, and any thoughts from last week's discussion of COVID recovery and our staff? I can tell you from my own work here in some of our COVID recovery staff, they have been so extra willing to talk with their colleagues about vaccine, so that their colleagues do not experience what they experienced in recovering from the illness. So that's one follow-up I have. And then also being champions for their families as we're beginning to roll out vaccine to our community. Now here in Maryland, we are at 65 and older. And since this is the Pennsylvania group, I am so excited to say that my 87-year-old father got his vaccine through Tower Health through his MyChart on Tuesday, doing well. I asked him whether he had a sore arm or a little bit of fever or headache or anything, and he said to me, "No, unlike that son-in-law of mine who's an Air Force guy, I'm a Navy guy. I'm tough, no problems." So we've had a good family discussion about vaccine in older adults, but so happy to see Pennsylvania continuing on and community vaccinations. Now I have several family members who are eligible who have not yet been able to access vaccine, waiting for their opportunity through their electronic MyCharts, but certainly helping them get up and running with their MyCharts. Okay, we've got a few folks who've responded to our request for today's topic of interdisciplinary teams, and thank you. I see Brian Gula has said all eyes and ears, meaning all together and working together. Kelly Longs has shared with us one area of importance is hydration. Absolutely, whether it's influenza or it's COVID or it's a GI virus, our nursing home residents are so vulnerable, and our staff as well, to the importance of hydration and an opportunity to work together. Teamwork makes the dream work. Matthew, I can't wait to hear you tell us a little bit more about that philosophy in your facility and how that works. And communication, and the theme in the literature reviews that I've completed, that's indeed what I've seen is the importance of communications in our teams and our silos. And Christina has shared with us asymptomatic patients, that you're discovering the long-term effects of the COVID illness. And in fact, you've taken my slide from me, Christina, because I in fact have issues about wounds, weight loss, dehydration, and your corporate leadership said, let's be sure we talk about those things. So Christina, we look forward to you leading that discussion. And Melanie says, let's share education and resources amongst our team members. And let's do that now in our team of Project Echo. So I'm going to go ahead and share my screen again, and we'll begin our discussion with our literature review. So what have I found in the literature on COVID-19 teamwork? And I can tell you the long-term care literature does not have much. In fact, it doesn't have anything that's been published in this last year specific to COVID-19 and teamwork in nursing facilities. So we certainly have some opportunity to contribute to the literature there. So I've gone to other settings of healthcare to see what's been published. And I have to say our surgical colleagues have been publishing quite a bit about teamwork. And here's one particular article, and it's talking about sustaining communications in a time with social distancing. and talked, it actually was a thorough review of the different platforms to do in multidisciplinary team meetings. And I won't go through the different platforms. They did in quite detail, and I'm sure your corporate leaders in determining how you do Zoom meetings have thought about the different types of platforms. But here's a reference if someone would like to see them in more literature. But what this article did share, I think the take-home messages I have from this article is when you're discussing individual residents, a multidisciplinary care planning meeting that's now using a platform, HIPAA compliance. So having password protected to access is important for HIPAA compliance. And many of our corporations have a HIPAA compliance built into their strategies for teamwork. But they also said, it's important for ease of sign-on. Can it be quick and effective? And flexibility. Some of our staff are in transit. They're driving during a team meeting, or they're moving from one end of the facility to the other. And so having a platform that's portable, that can be accessed from their smartphone or their tablet versus their computer or their phone. So those were the take-home messages from this review for trying to manage teams in a time of social distancing. Here's an article that talks about doing multidisciplinary team meetings. When we do them in a conference room, we tend to have a single staff member identified as the leader, and there's that visual context that keeps us all in line. And so this article actually provided a checklist for multidisciplinary meetings that I thought I'd share with this group. And I'm sure we're all recognizing these informally, but the importance of making sure that the IT issues are addressed. We had to change from one platform to another for my multidisciplinary rounds in my chronic vent unit. And of course, when the first meeting that we transitioned, where there was a 10-minute delay while everybody got on to the new platform. And so there's always that with a new platform, making sure individuals have the opportunity to do a dry run, make sure they can access it. They've got the right password. And then having a checklist of who's speaking when. And in fact, we did this informally when we were all in our conference room, but we began to see a lot of folks speaking out of term early on when we went to a platform for multidisciplinary rounds, and particularly for those who are not on visible. And the importance of actually being on camera and seeing each other does help with attention. It also helps the visual cues. So you can say something in one way, but those hand gestures, those facial expressions that we use, those nonverbal forms of communication are lost when we are all not on camera. And so encouraging platforms where we can see each other and share in both verbal and nonverbal forms of communication, very important. And then ensure that we have the attendance correct and documentation, and just as we do in our ECHO projects, take the time to be sure, and the chat box is often a good way to ensure you've gotten everybody listed who's participated. So there's a literature that just speaks not just to COVID, but we're talking now about post-COVID and how we manage our very important staffing and human resources. We're talking at Johns Hopkins Medicine about many of our roles will not return to full-time in-person roles, that many roles can be at least partly performed outside of our facilities. We're talking about support staff, administrative staff, and the approach of using more of a hotel accommodation for office space and having less offices. Individuals don't have their own office, but more of touchdown space for when you are on site. I would bet that skilled nursing facilities have done more of this type of approach to staffing than many of our academic centers have. But there'll be a new way of working. Many staff have enjoyed the time at home. They have the ability to care for older adult family members, sometimes younger adult family members with more flexibility. The time they might spend commuting, they can put to stress reduction, exercise, quality of life. And so the way we do business in the United States of America, not just nursing homes, will change due to COVID. And following that HR literature is very fascinating and something that not just in nursing facility settings as we look at our interdisciplinary teams and how we interact, but going forward post-COVID, and we look forward to that post-COVID. So I wanted to share a little bit of that literature, look forward to having some of this literature in our nursing home literature. But for now, I'm going to stop sharing my screen and ask the group to begin to unmute and talk about teamwork, COVID care, and some of our other quality measures, such as pressure ulcer reduction, unplanned hospitalizations, unplanned weight loss that is coming with that long-term COVID care that we're seeing. So let me stop talking and ask the group to begin to share interdisciplinary team thoughts.
Hello.
Hi.
Hi. Yeah. Hi. We just noticed that a lot of our patients, we had a few who had COVID and then who had like a lot of respiratory issues who saw a decline right away. But a lot of our COVID, especially related deaths, had to do with like failure to thrive related to COVID, which I don't think a lot of people are like fully aware of that. Like I was even like, I didn't know that was like a thing until like I like start like talking to the physicians about it a lot more. So we've seen a lot of deaths related to like just a failure to thrive status post-COVID. We actually have a patient who had COVID in the very beginning for us in the beginning of November. She just had a steady decline. She has a lot of comorbidities, but she just transitioned to hospice care, but she has a stage 4 pressure wound that just like opened up, and they're saying that it's attributed to her COVID.
Wow.
Which that's very interesting too, just as like the changes in skin related to her having COVID, which everyone I think thinks respiratory, but it affects other things too. I know personally I had COVID, and I had a lot of hair loss, and my skin like is very, very dry, like was very dry. My hairdresser actually said that like a lot of her patients who had that, they experienced a lot of hair loss, and they've had like dry patches in their scalp, which I thought was interesting as well.
Wow. So Lindsay, you're even getting to how we might assist our residents with their personal care post-COVID.
Yeah. Yep.
Lindsay, what is your role and what facility are you in?
I'm the CNE at Quakertown Center.
Great. So at Quakertown, Lindsay, what suggestions do you have for that personal care of your post-COVID residents?
We're just trying to take extra special attention to the other things that you wouldn't think of. Like I said, I think everyone focuses on respiratory and doesn't focus on the outside things. Therapy has been a big help. They see every single patient who has had COVID. They're actually following back with them a few weeks later just to see if they're still doing well as far as their like functional decline. And then as far as nursing, we're taking extra special attention to skin care, making sure we're doing skin rounds more often than not, and doing a lot of education with the CNAs about the changes that can happen related to COVID that you wouldn't think about.
Good. And it sounds to me like then you're using your interdisciplinary team approach in all hands on deck addressing COVID care for your residents.
Yes.
Yeah, terrific. Good. I'm glad to hear that you're recovering as well.
Thank you.
And being part of the team that's part of the solution here. Great.
Yeah, trying to just take care of the residents. That's what we're here for.
That's great. Good. Hey, Matthew, you told us teamwork makes the dream work. Where are you working these days? What facility?
Sure, yeah. So we're at Hopkins Center.
Mm-hmm.
Yeah, so we just really emphasize that with our staff that, you know, it's the responsibility for all staff, you know, if we're going around, you know, helping each other out, whether it be answering call bells, or, you know, nurses helping CNAs and, you know, CNAs, you know, talking with, you know, nursing and therapy. So, we really try to take down those professional silos that people tend to build up around themselves to, know that we're all in this together to, for the best care for the residents that we can provide.
Mhm. Good, good. Matthew, did you see early on with COVID some of the other quality measures beginning to be challenging, like increase in pressure ulcers, increase in falls, functional decline?
Yeah, no, absolutely. I mean, with falls, because we had all the doors shut, so that was more challenging. So we, got some creative monitoring devices we put together. And then for, pressure and skin, as other people were saying that, yeah, we've really noticed, they would start developing kind of rashes and, would decline rather quickly. And it seemed like no matter what we kind of put in place, it wasn't really helping. So it was more that failure to thrive. After initially getting it, they would kind of recover, but then they just wouldn't bounce back from it.
Oh, can you tell us about your creative strategies for fall prevention?
Yeah, really, we got baby monitors.
Wow.
And, yeah, put those in a lot of rooms, and that really helped us to, this way staff wouldn't have to go in and out of the rooms all the time, but could also keep a good eye on the resident as well.
And they had the voice.
Yeah, and they had the voice cueing, so we could talk through the monitor to be like, hey, sit back down, or yeah.
Yeah, great. So very creative and very needed, right?
Yep.
Good, good. Thank you.
Thank you.
Let's see. How about Brian? Communicate. We're in it together. Sounds like the same. You're resonating with Matthew's comments. Can you share a little more?
Yeah, pretty much. With the changes, and we all know it changes every day. Constant, whether it's bed moves, whether it's something with the residents, we have to communicate, and just like I said, we're all in it together. Like everyone's important. It doesn't matter what position you're in at this point or anytime.
Sure.
Like we do room changes, we do this, we do that, and it's important to go out there and tell people why, because they want to know why are you doing this, why do we keep doing this. So it's good to talk about it, and that also gets them, I believe, they'll communicate back to you, like if they see something, because you're opening up to them, making sure they know why and this and that, and they also will come back and hopefully tell you things also, so you're all in it together, do what we can, the best we can for our residents and staff. That's pretty much what I meant by all that.
Sure. Brian, room changes are something we really try to avoid pre-COVID, but as you said, very necessary when you need to put an individual into a COVID unit because they've asymptomatic and positive, or they're new to the facility and trying to get your observation unit appropriate. How long does it take to do a room change, and what are your best practices for that? What have you found works?
I don't know about best practices, but it does take, you're supposed to take, I believe it's a couple hours for each room if you clean it properly. So it does take a long time when you have several room moves to make, and it takes several people to help with that. So.
Have you found a time of day better based on the way your facility flows?
Well, best time of day is to start early, but a lot of times we had afternoon calls and we'd have to start late. So then it would go late into the evening. So that made it more difficult, but we still got it done.
And how do you do the communications from nursing assistant, nurse to housekeeping?
Well,
does that work for you?
We kind of know early on because we tested some residents in the morning, and they were positive. So we have a call with corporate, we do our map and change things around. So we basically just tell everybody, stand by, because more than likely we're going to be moving people. And right after that call, whatever time it is, 3:30, 4 o'clock, we have a meeting and we just start. A lot of people stayed over, different managers, and just do what you have to do.
Yeah. Sure. Well, thank you.
Sure.
Christina, you talked about weight loss and dehydration. Can you share some strategies on that, managing those long-term effects of your COVID recovering patients from an interdisciplinary perspective?
Sure. Good morning. So we work very closely with our dietitian. She has really stepped up with being involved with all of the patients and, seeing if certain supplements don't work, what else can we do outside of the box for people that don't normally like the regular shakes that we give and whatnot. But she's monitoring weights and just making changes as she sees fit according to what, because if you have somebody that's on a thickened diet or a dysphagia diet, certain things they're not able to take in regards to supplements. She did find this Jello that she uses that the residents have really seemed to prefer over the magic milkshakes and whatnot. So we are looking very closely at weights. I report it on my core every month, and then her and I get together and try to figure out what kind of things we can tweak. She meets with the unit managers, that kind of thing. For the people that are dehydrated, we started what was called a hydration cart. We have our therapy department going around. When we were in the thick of COVID, they were coming around with a snack table of things that you would not normally find, like cupcakes and tasty cakes and Hawaiian punch and things that had added calories and added sugar, so that the people that were actively losing weight were more enticed to take these things that you wouldn't normally find on a regular snack cart. It would be potato chips and pretzels and just special treats. And what we were finding was that a lot of people that had lost a significant amount of weight due to their COVID diagnosis were starting to then gain that weight back. We have continued with the hydration cart. What we do for the people in the observation unit, since they're not able to go into that unit, we have like Hawaiian punch or, a special kind of drink that's not normally found on the formulary. We pour all of that into little cups. We take them over with a tray, and then the CNA is then delivering that to the residents for more hydration. Because now the new thing that we're finding is there's been an uptick in urinary tract infections.
Why do you think that is?
I think because, a lot of people are just preferring to stay in bed because there's no socialization.
Yep.
A lot of them don't have a reason to get up every day and socialize. We do a lot of our activities through live streaming through the TV. We have bingo live streaming. We have some people that remotely will do things for us. We have a harp player. We have, there's a lot of different people that have during this time stepped up and have done remote things so that we could live stream them into the TV. But it's very difficult to find things that everybody is interested in. Not everybody is interested in bingo, and not everybody is interested in watching TV and those kind of things. So I think a lot of that has to do with socialization. It's just a big snowball effect with everything, all the different factors that come into place.
Yeah. You've touched on wonderful examples of your interdisciplinary team with your recreational therapists having a role in getting people out of bed and preventing functional decline. And I certainly agree with you that urinary tract infections have increased because people are less mobile and they're not as well hydrated. And hydration is probably the biggest, in our medical literature, one of the most effective ways of preventing urinary tract infections is to maintain hydration. So your approach is a fantastic example of interdisciplinary work to improve a clinical outcome related to COVID-19, that being urinary tract infections as well as functional decline. So thanks for sharing that. What's your role and which facility are you in, Christina?
I'm at the Wayne Center, and I'm the director of nursing here.
Fantastic. So you've got a team of folks that are working. Some of these strategies you're presenting to us, Christina, do they come from you in the top as director of nursing, or do these bubble up from your nursing assistants and your?
Oh, it's a large group process. It's, everybody, has had different input. Everybody's had a different experience. With COVID, we've had, I think it's either, brought people together or tore them apart. And we've been lucky enough that we have a lot of upper management that has stepped up, and we have a lot of people on the management team that are now doing dual roles and doing things that is out of their comfort zone. But it's definitely a team approach.
Great. And when people are out of their comfort zone, they get support from other colleagues that boost them up, right?
Yes.
Yeah, fantastic. Christina, what strategies are you using to get this group effort and these suggestions up so that, in fact, you have a plan and you implement a plan? Let's say your increased hydration plan. How do you communicate that type of approach?
Well, we're lucky enough that our center is fairly small. We're able to, we're out on the floors all of the time. We're doing a lot of staff testing and resident testing, although it has decreased a little bit this week. But we see each other in passing, and I think we just let everyone know that everybody's voice is heard, and no suggestion is out of reach or stupid, or and that everybody is heard. It doesn't matter if we use your suggestion, but keep the suggestions coming.
Great. So it sounds like you're using that strategy of huddles, in a sense, one-on-one, asking those who are doing the job every day, what do you think we could do differently and better? And then conferring, and then with leadership, formalizing these plans. And then are there times when you'll do little pilots where you might try something on one unit but not all the units to see if it's working?
Usually if we're doing a pilot, it's the whole building and everybody is involved. It may work better on one floor as opposed to another floor, but we don't know that until the pilot takes off and running, and then then we regroup and see what's working, what's not working, what can we do differently.
So you collect some data on your outcomes and
Yes.
find opportunities to further refine your actions. So fantastic. Thank you.
Sure.
Melanie Molnar, you talk about sharing education and resources. Can you unmute and tell us about your strategies for sharing education, and tell us what facility you're at?
Hello, I'm at Crestview Center in Langhorne, PA. So we have a lot of education and resources that come from all over. We have a lot that come directly from Genesis. We share those throughout the facility in like our AM meeting call, different huddles that we do on the units, really a lot of different ways. But a lot of the resources and education that we get, I think we're lucky to be a part of Genesis where we have this available and have so much support from our corporate group. So weekly we do a call with them, and they, really give us information to share with the staff. So for example, yesterday we had ours, or on Tuesday, and it was about managing expectations for, the side effects that staff may experience getting our second dose for the vaccine. So I think that's very important to share with our staff so that they know they may not feel very well. And that just goes a long way, that transparency. And then also sharing that with our families. We still do our family Zoom call to let them know what's occurring here at the center. So there's a lot of different ways.
Good. So that corporate education, how do you then disseminate it to your staff at your facility?
So we do encourage all of our staff from, direct care staff, different department heads, managers to attend the calls if they're available. If not, we do share those golden nuggets of information in morning meeting. So again, just lots of different ways on making sure that all the staff is aware. And if they do have doubts about certain topics, Genesis was thoughtful enough to create these Ask the Doc sessions. If we had any employees doubtful about getting the vaccine, and all we had to do was schedule a session for our center to be available to, answer any questions, anything like that. So we do have a lot of resources available to us, and I feel lucky that we have them.
Good. So the Ask the Doc sessions were to address staff vaccination?
Yes, correct.
Any data at this point to say whether those sessions were effective in increasing your staff compliance with vaccination?
I would say since they're still ongoing, I don't think we're able to have many, trends yet be concluded from them, but I do know a lot of facilities have opted to have them. So they've been very impactful, I think.
Great, good. So something that you're all working toward, a very important area for COVID-19 is continuing opportunity for vaccination, and staff who waited the first time want to see the outcome from those who went ahead, but now an opportunity. I also see with our national news and all the discussions of those who want vaccine certainly contributing as well to that second wave opportunities. So good, thank you. What facilities haven't we heard from in the topic of the team approach to quality improvement, not just COVID care itself, but our very important quality metrics in our nursing facilities, maintaining physical function and cognitive function, reducing unplanned weight loss, preventing pressure ulcers, unplanned hospitalizations. How have our teams been working effectively, or where can we do better? Anyone want some guidance as to a particular challenge you have in your facility right now? Maybe one of your quality measures is going in the wrong direction. And let me ask if Pennsylvania is experiencing what Maryland is experiencing, unannounced surveys for infection control to review your infection control practices. Are those happening in your facilities in Pennsylvania? Lisa, I see you shaking your head. Yes, tell me.
Yeah, we've had them over the last year. They've come out twice for infection control surveys. Overall, they weren't able to find any deficiencies, which is good. But yeah, they absolutely are coming out, asking a lot of questions, digging through a lot of charts. So I know for us, that has occurred twice already.
And you're at Crestview, right?
Crestview Center, yeah.
And were these during COVID times or pre-COVID?
No, during COVID, yep.
And were they focusing specifically on your infection practices for preventing COVID, and then your units were you caring for COVID residents at the time?
Yeah.
And so no opportunities there for quality improvement? You are on top of things?
Yeah, like I said, we were lucky enough we didn't have any deficiencies, but we continue to stay on top of doing those infection control walking rounds. When we do identify things, we are trying to address them right away. So it's a work in progress, but as far as the surveys go, they've gone really well.
Good, good, good. Here in Maryland, they haven't gone so well. I'm not saying Genesis facilities, but in general, but the leader of those infection surveys contacted me last week and actually wanted to come on our Project Echo call this afternoon and Tuesday afternoon, where we have Maryland facilities, just to discuss that. And I said, no, this is our forum for education and working together, but I would certainly bring that topic up. And just have a discussion. But thank you. We don't want any surveyors on. This is a chance for us to work together and troubleshoot and brainstorm. But thank you for the notice. So I think, Tara, did you shake your head yes as well, Tara Winter?
Yeah, I was actually going to say that we've had, I'm at Chapel Manor, we've had 3 infection control surveys.
Mm-hmm.
And my perception of the surveys were that we were actually educating the surveyors. So I felt as though they were very overwhelmed with the amount of documents that the Department of Health were requiring them to obtain from us.
Mm-hmm.
And more or less, we were educating them on our processes and that they were still trying to catch up
Mm-hmm.
with their learning.
Mm-hmm.
I have to agree with you, Tara. I felt that too.
Mm-hmm. Mm-hmm. And that's because you're in the trenches dealing with COVID care every day, and they're at I won't say a higher level, I hate the term higher level, but they're at an administrative level. But I would imagine in some ways your sharing your documentation and your processes actually helps you check the boxes to say, yeah, we're doing this. And while you're educating them, you're in fact educating your staff and your leadership on your effective practices. So kind of confirming what we saw in that literature about communication, checklists, and being sure we've got processes that we're following. So
I actually felt as though, you know, I've always really liked my field office. I don't know if in Maryland you call them field offices, but the designated office that oversees my specific facility we've always had a good rapport with them. They're very understanding, but they still hold you accountable.
mm-hmm.
You know, I feel like there's this new level of respect they have for us.
Yeah.
And almost like an awe of what we're doing, and that, you know, we just continue doing what we're doing. And I feel as though, you know, it kind of breaks down those barriers between us, that, hey, we're on the same side still, you know, we want the same outcomes. And this whole experience has assisted with that.
Wow, you've touched on some really critical points. Hospitals and hospital leadership, hospital staff and hospital leadership have new respect for nursing home care and providers with what we're doing. And I've seen that across Johns Hopkins Medicine, and the willingness to partner and develop pathways for transitions in care, to recognize opportunities for better testing. And we now at Hopkins have a program for nursing home providers can call our Hopkins Access line 24/7 and reach a pulmonologist or a hospitalist expert in COVID care to help the team manage COVID in the nursing facility. And wow, those types of partnerships did not exist pre-COVID, but recognizing the quality of care and the efforts in the nursing facility is, there's a silver lining in our COVID care Tara, that you've brought to light that I think we should acknowledge, and taking those opportunities now to continue these partnerships with in areas non-COVID care. So wonderful opportunities for us. So we're not only are we educating state surveyors, we're educating our hospital teams with whom we partner for clinical care, and home care agencies as well, and primary care providers for our short stay residents. I see systems of care developing out of COVID, necessary for COVID care, but will continue on well beyond COVID care. So thanks for bringing those up. So we indeed are the educators for our partners. Michael Furlan, I was actually going to call on you next, so thank you for sharing with me. You're having connection problems, microphone problems, but you put a nice summary in the chat privately for me to review with the team. And you've said it's not been an issue with the Department of Health visits, but when they have come, they've been impressed by your your infection control plans and your implementation of them and your documentation of them. But you shared something new you're doing, the touchless thermometer at your entrance and testing staff twice a week, and utilizing the patient-specific precautions on your non-COVID units. So, so you've checked off a few areas where you focused on infection control during this COVID time, and collecting data and acting on the data. So, from a quality improvement perspective, thanks for sharing those with us, Michael. And Adam, since you're representing corporate, make sure they have better connections. I just want to see if Adam's listening.
I was actually typing in the chat box. I was just going to say that I've heard anecdotally, just to Tara and Lisa's point both, that there's been a lot of resets, like relationship resets of folks who, you know, otherwise didn't know what we do every day. Because we haven't been mom and pop shops for a long time. We've been taking care of a lot of acutely ill patients. We've been taking care of more complex residents over the years. And, you know, we realize they need a home and a place to live and people to take care of them. And we take everybody we can possibly take. And that's a challenge for our nursing staff. It always has been. So we meet that challenge. And this is just another challenge that they've all met. And those relationships have been reset in a lot of cases where there is a newfound respect and a newfound understanding that everything we do is for the benefit of the residents. And the staff come to work every day and fight these challenges for the residents. And I think the communities, the vendors, the hospital partners, the surveyors, all those folks are now getting a chance to see what that's like, because they may not necessarily be on the front lines, but these folks are. And so it's a lot easier to throw stones when there's not a pandemic, and now there's a pandemic. So it seems like some of those relationships are being reset, and it's just good to hear anecdotally that that's working. So, and you can reach out to me with the IT issues, by the way. I'll help you.
There you go, Michael. We solved a problem for you. We're working on it. I love that word, reset. Yeah, that is a very good example of another silver lining of the pandemic in our sector of healthcare. I'm going to say that Project Echo needed to be reset. Victor, you got your, yeah, I saw you look up, Victor. When we looked at the curriculum, the PowerPoints, the videos, I've told you before, they were way too basic for what skilled nursing facility providers have, nurses, nursing assistants have been doing. And you're resetting as well in this curriculum as you're rolling out new sessions, because you're the leadership of Project Echo has heard. We're dealing with way more than you think we're dealing with, and we know how to do it, but we still have challenges, and let's face those challenges creatively using your IHI quality improvement principles. So I set you up, Victor. Time for you to speak to us.
Very timely, and I was just about to say that how wonderful is to listen to the conversation. Thank you, Michelle, so much for sort of putting this discussion into this quality improvement sort of thinking approach, which is very much what I think Echo is to learn about. You know, how do we sort of bring the content and improvement together to accelerate the sort of better results or achieving those results. I think it's just an excellent conversation. I was making notes and I was like, okay, I'll ask this question, but the answer is given. So we have the discussion about the leadership support, the teamwork, not only for care delivery, but also for the quality improvement, you know, reviewing together plans, data, identifying priorities, you know, thinking about the changes, you know, as Christina had mentioned about, you know, once in a while, you know, this is a process, you know, the group discussion about defining changes and you know, putting them in quality measures. You know, those are just excellent examples. What I would only add at this point, as we will be moving forward, you know, we'll be having more conversations about in context of the improvement, but also write some, I don't know, I would suggest, and I will suggest to IHI, is just, you know, encouraged to write success stories about, you know, or maybe that sounds too big, success story, but success about how do you as a team implemented that improvement. You know, how did you pick up on this urinary tract infections, for instance, and identified as a priority, and how did you tackle this issue? I think it's a wonderful learning for everybody. So I would strongly encourage you to do that. And we talked about measurements. I was thinking before this session, okay, maybe one of the questions I would like to learn more about how do we measure the changes. As we say, improving care requires changes or processes of care, but not every change leads to the improvement, right? So how do we measure from implementing the change or smaller scale change and larger scale change? And you do that. So this is just fascinating. Thank you so much. I really appreciate it.
Thank you, Victor.
Yeah.
I'm going to share my screen again. And let me get to the next slide. So I wanted to just highlight in my discussions with your corporate leadership, Erin and Angela Carr here in Maryland, and Adam, we wanted to be sure we did touch on non-COVID care, and through our conversations, indeed we did. But one bullet I have to add for the 2 o'clock session is urinary tract infection. So thank you. I will add that to our quality improvements that we're working toward with our teamwork. So our sessions, as we're taking away the importance of teamwork and our quality improvement strategies of identifying an opportunity for improvement, planning how we will do so with our one-on-one huddles and our structures to actually get to what it is we're trying to improve in our 5 words or less, and then actually implementing the plan, collecting the data on outcomes, and then acting to refine our plans. Let's plan for the topic for next week, which is advanced care planning. I'm going to try and invite one of my colleagues here in the Mid-Atlantic Medical Directors Association, Dr. Ravi Pasi, who's a medical director in both skilled nursing facilities and assisted living facilities. And he's very interested and well-read and thoughtful in advanced care planning and how all of our team members address advanced care planning with our long stay residents, our short stay residents, and their families and loved ones. So not just in the time of COVID care, but in general. And so think about an opportunity there, and particularly related to COVID. I'm sure we all had to face the issue of, well, will we hospitalize? Will we not hospitalize? Will we offer monoclonal antibodies? How will we do vaccines for end-of-life care residents? And so whatever topic it is related to COVID or not COVID care, let's think about advanced care planning for next week, okay? So with that, let me stop sharing my screen and see if there are any final comments from the group. Anything related to staff vaccinations, a hot topic right now as we continue on, or COVID recovery that we talked about last week. And anybody who didn't get a chance to talk that wanted to share their perspectives, because okay. So with that, go out, be well, be safe, continue the incredible good work, continue to reset. I love that word, Adam, thank you. And everybody have a good afternoon, okay? Take care. Bye-bye now.
Thank you.